is Ifoma Obadike. I'm a family nurse practitioner student. I am going to be doing musculoskeletal assessment on you today. Will you please look at the camera and tell me if you give me the consent to do this, because this is going to be on YouTube under Unlisted. Do I have your consent?
Yes, you do.
Okay, thank you. So I'm going to start this exam. I washed my hand already while I come in here. Then I'm going to start with her hand. I'm going to be inspecting the hands. I'm inspecting the hands for any swallow, any deformation, any redness, any muscular dystrophy, any nodes, or any joint for symmetry. And I'm doing both sides, so bilateral, so that way I can make sure I compare both sides. Then now I move on to hand palpation. So I'm going to start hand palpation. I'm going to be palpating the distal and the proximal interphalangeal and the metacapsule phalangeal. So I'm palpating it. I'm palpating it for any node, any tenderness, any pain. Do you have any pain?
No.
So I do the same on both sides. I'm palpating for any pain or any tenderness, any node. And there is nothing, it is normal, the patient did not experience any tenderness or anything, so our pain. So I'm going to move down to range of motion of the hand. So you see patient's ability to make fist. So I'm going to ask you to make a fist. So then extend it. So both hands, you flex and extend fingers on both hands. So flex, extend. So and then for the abduction and abduction, I want you to open your hands like this. So for the abduction, flex and extend both hands, also abduction of both hands. So I want it away, open it like this. Then together is abduction, away. So away over the finger, then abduction, like this, away from the finger, abduction. So now I'm going to go to the wrist. Though the wrist, I'm going to be inspecting the wrist. I'm inspecting the wrist for any swallowing, any deformity, redness, atrophy, node, and for symmetry, joint symmetry. So I'm inspecting both wrists. And after the inspection, I'm going to be palpating the wrist. I'm palpating the wrist, including the metacapsule and the carpal bones of the wrist. So I'm going to be palpating the wrist. I'm palpating it for any node, any tenderness. I'm palpating the wrist. So now I'm going to go to the wrist range of motion. So in the wrist range of motion, I'm going to ask the patient to flex her wrist 90 degrees and extend it. Flex the wrist downward and then upward 90 degrees. And when we do the wrist abduction and adduction, so you want to see the wrist deviation. So I want you to move the wrist like this and away towards the body. Away is abduction, towards the body is adduction. The same thing I do on here, this on the side. So I'm also trying to find if there's any pain or tenderness. Now I am going to the Tenno test, the specialty test. This test is usually what we use to check patients if they have any positive capillary, like when they are typists, they're using computer for a very long time. So we want to check the hyperextension of the wrist and tap the medial in the middle of the finger, or a reflex with a hand reflex hammer. Then a positive pain signifies a radiating down of the pain in the index of the middle of the hand, or the ring finger shows a positive sign on this test. So I'm going to use this, and I'm going to check using the hammer and here, and I'm going to see if patient has any pain, or maybe sometimes I have to occlude this and see if what happens. So all right, that's one test. So for the next specialty test is a Flentel test. So this, I'm going to flex the wrist 90 degrees and maintain it at least for 10 seconds. And a positive test is pain on the media. So at this point, I want you to do this for me, and she'll hold it for 40 to 60 seconds. And if there is any pain, and do you feel any pain while you're doing that?
Yeah.
While you're doing that, so if there is any pain, that indicates a positive test for the Fehlern's test. So thank you. So the next one is going to be the elbow. So I'm going to go to the elbow. I'm going to start like every other thing we do. We start with inspection. So I'm inspecting the elbow for redness. I'm inspecting it for any swollen, any node, any joint symmetry. I'm inspecting both sides, comparing those both sides for any redness, any node, any joint symmetry, redness. So now that I've done that, I go to palpation. So I'm going to palpate the elbow. I'm palpating the elbow for any, for pain, for swollen node, and then I'm going to palpate the, extend the surface of the ulna and the Ockman process, and press the lateral end of the epicondyle, looking for pain in the area, indicating that the patient has a ball game and baseball elbow versus the tennis elbow. So I'm inspecting for any pain, and I'm going to do the same on this side of the patient. I'm trying to see if I'll palpate for any tenderness, any pain on this elbow. So now that I'm done with this, we're going to go to the elbow range of motion, which is the extension and the supine. And so we're going to supinate and then pronate each hand. So I want you to do this for me. Supinate and pronate, supinate and pronate. That is the range of motion of the elbow. So I'm going to the shoulder. In the shoulder, I will be inspecting the shoulder, both the anterior and the posterior shoulder. I'm inspecting for any swallowing, any swelling. I'm inspecting for deformity, redness, atrophy, and joint symmetry node. So I'm going to check both shoulder, and I'm going to make sure that they are symmetrical. There is no any deformity, one being higher, one being lower. So now that I finished that, I'm going to start with my palpation. I'm going to be palpating the joints, the bicep groove, the acromioclavicle joint, where, let me extend the hands like this for me. I'm going to be palpating that. I'm going to be palpating the humerus and the coracoid process and the subdeltoid bursa. I'm going to be palpating that. This is the joint, the acromioclavicle joint, and then the bicep groove and the torso and of the humerus. So I'm going to do the shoulder range of motion now. So the shoulder range of motion, I'm going to flex the shoulder 180 degrees. So you have the patient to 180 degrees, and then extend the shoulder backwards to 60 degrees without the scapular motion. So the arm goes behind, and then I'm going to do the with arms on the side, and which is the abduction and adduction at 90 degrees. So the arms on the side, and then I'm going to also go up like you're scratching your back, like this, and then like this. So that is extended your range of motion of the shoulder. So let's do it one again. You stretch your hands at 80 degrees, you bring it back, we go back like this, and then we go the hand like this. So like you're scratching your back, and then with the hand, this hand going and touching the scapula. So now the next one that I will be doing is empty can test. So in the empty can test is a specialty test. So in this test, you test for sonate strength and the possible rotation of the calf tear. So patient will straight their arms with thumbs pointing downwards, with their thumbs pointing downwards, and then you pushing the hand towards, and you are trying to find if it's weak, and if it's weak or pain, it becomes positive. So I'm going to push it down. Any pain or
No.
if when I push it, I want you to resist. And so that is negative test for that. So I'm going to go down to the head and the neck now. So in the head and the neck, I'm going to be inspecting the head. I'm inspecting the head for any deformity, any posture, any abnormal posture, which I don't see any in this patient. So I go down to effect palpation. So first you place the two fingers of each in the hand in the front of the vagus of the ear, and have the patient open their mouth. So you are testing for the TMJ. So I'm gonna ask you to open your mouth with my two fingers and have it here. Can you open your mouth or say something like ah, open and close? So I'm checking, palpating. I'm asking patient, do you have any tenderness?
No.
No tenderness. So now I'm gonna go to the mastoid, clavicular, and the cervic. So I'm gonna go down. I am palpating for any tenderness. I am going to the spine, cervical spine. I am palpating for any tenderness. I'm going to the paracervical muscle and the trapezius muscle. I am palpating for any tenderness or any pain. Now that I'm done with that, do you have any pain as I palpate?
No.
Okay, so now I'm going to go to the range of motion of the head and the neck. I'm going to ask patient to flex is to tuck your chin down to your chest, and to extend is pull your head backwards, and the lateral is turn towards your ear like that, and then to the other side corresponding shoulder. So now I'm going to instruct you now to open and close your mouth, which we already did, testing the axillary muscle. So we now assess the degree of the maxillary opening. The patient should be able to place 3 of their own fingers verbally and place it in their mouth. So, can you open your hands, mouth again for me? Open, close, open, close. So, thank you very much. That brings me to this range of motion. So the next test that I'm going to be doing this time is going to be the spiral test, the spiraling test, which is the cervical compression. In this test, we try to avoid it in elderly people. We ask the patient we kind of find out if the patient has pain. So we push the head and the neck of the patient side to side and put a pressure on the head. So can you move your head for me to one side, this side, and then to this side? So what we do is that we put a pressure on the patient, and we want to put a pressure down here. We want to see if the patient is having a radical pain as we put this pressure. And this is a test that we should avoid on the elderly or fragile people. So the next test we are going to do now is going to be the feet and the toes. So at this point, I'm going to adjust my camera. So if you don't mind laying down for me, so that way the camera will be able to pick up your feet. So with the feet and the toes, I will be assessing this feet and inspecting this feet first with checking for swollen, any colors, any deformity, any corn, and I'm inspecting for nodule. I'm inspecting for any feet warts. I'm inspecting for any flat feet. Flat feet is usually best when the patient is standing. So, but at this point I'll be continuing. So not right now. So when I finish this, I'm going to be palpating, go down to palpation. So I'm palpating for interdigital neuroma. So I'm going to be palpating here for the interdigital neuroma. I'm palpating for any tenderness or any pain. Do you have any tenderness or pain as I palpate you?
No.
No. So I hope the camera is seeing everything now. So then I'm palpating for any, I go down to the plantar fasciitis. So I'm palpating for the plantar fasciitis. This is usually common with people who standing for a very long time in their job. So I'm palpating for plantar fasciitis. I'm asking patients, do you have any tenderness or pain?
Yeah.
While I palpate, I'm going to do the same on the other feet. I'm going to ask any tenderness or pain as I palpate down.
Yeah.
So, and I'm going to go now. Next, I'm going to go to the these two and the posterior interphalangeals. So I'm going to palpate them one at a time. I'm checking for tenderness on the pain. I'm doing the same on this other feet, checking for tenderness and pain. So then I'm moving down to the metatarsals. So in the metatarsals, I'm going to be checking also, doing the same thing. I'm going to be checking for tenderness and the pain. So then I'm going to do the range of motion on the feet. So now I'm going to be the flexion and extension. So for the flexion, extension, flexion, extension. So for the inversion is in, you curl the feet in. For the eversion is out. So I'll do the same on this other leg. Flexion, extension, and then eversion, and the eversion. So in is in, eversion is out. Okay? So now I'm going to go to the ankle. So at this point in the ankle, I'm going to look at the ankle. I'm inspecting the ankle for any swollen, any tenderness, any discoloration. There is none that I can see. I do the same on this other ankle. There is no pain, no tenderness, no redness, no discoloration of any kind. So I will start down by palpating the medial and the lateral malleolus and the Achilles of the node for tenderness. So I'm going to get this up. Can you do this for me? So I'm going to start palpating. I'm palpating the Achilles for tenderness and the node. I'm palpating the lateral and the medial malleolus. I'm palpating for any pain, any tenderness. Do you have any pain as I palpate this?
No.
Okay, so I'm going to do the same here. I'm going to palpate the Achilles. Can you put your feet like this for me? So I'm going to palpate the Achilles back here. I'm going to palpate for tenderness, redness, or any pain. So I'm doing the same here on the, this is the lateral medialis, and then doing the medial medialus. So no, any tenderness or pain?
Yeah.
So the next is going to be the range of motion of the ankle. So I'm going to start by dorsiflex. With dorsiflex, your toes for me, your ankles, and then the plantar flex, and then the ankle rotates it in the circle. So you do extend and do extend, and then so you can just do a circle like this. So circle your feet with what I've just done here, or is the range of motion of the ankle. So let's do this again on this one. So you repeat the same thing on this one: dorsiflex, plantar flex, and then rotate in and out. So you can just rotate it around for a whole circle, which it got everything. So we go to the knee. On the knee, for the purpose of this exam, my patient has a pens, and I'm going to leave the pens on, but in a normal clinical setting, the patient won't be having a pens, he will be having a short, so that way I can expose her knees and be able to see what is happening there. So for this, I am going to be looking at the knee, inspecting it for any swollen, any node, any redness, any ligament, like vergos of deformation. So which at this point I don't see any there of that. Then I go to palpation of the knee. I'm going to start by palpating the super patellar pouch and the the popliteal fossa for Baker's cyst. So this is my popliteal pouch. I'm inspecting it, I'm palpating it. While I'm palpating it, I'm looking at patient movement. I'm looking at whether she has any seeing any pain, and I'm asking her, is there any pain or tenderness? No. So now I go down to the popliteal fossa, which is also for the, I'm palpating for the Baker's cyst. So I want to bring the leg like 90 degrees. I'm palpating any pain, any tenderness.
No.
So and now also do this on the popliteal fossa for Baker's cyst. Any pain or tenderness?
No.
So I do the range of motion for the knee, which is the extension at 0 degree, just straightening her legs out like she have now, and then flexion is putting it 120 degrees angle. So extend, and then, so we do this one at a time. We don't do it the same. So put this leg down for me, so straight. Okay, so we do the same on the other leg. Okay, so now we go to the specialty test. The specialty test we're doing is going to be valgus stress test. That's going to be the #1 specialty test for the knee. With the valgus stress test, the knee is slightly flexed at about 20 degrees angle, and then I place my arms on the lateral of the knee and it grabs the inner of the ankle on the opposite hand for that. So I'm going to ask you to do this for me. So let me stand here. So, and at this point, I grabs this area on the middle of the foot, and I will have to move from the ankle opposite with the hand, abduction, abduction, adduction, abduction. I do in, abduction, abduction. So I will also do the same on this leg. So I'm gonna ask you to flex it like 20 degrees. So I will move, do the same, abduction, abduction. I move the in, flex to in, out, extend, flex in, extend, and then I'll move abduction, abduction. So at this, so the next one I'm going to do is a valgus stress. So with valgus stress, the knee is flexed 20 degrees also. Then you place placing the inner arm in the medial side of the knee, and then grasping the foot or the ankle with the opposite hand. So I'm going to place that and I'm going to grasp it. So I'm going to extend it for 20 degrees, grasp it, and then I'm doing the abduction, abduction, and you're going to hear it pop. Abduction, abduction. So, and the next is going to do the same also on this leg and in the knee. Abduction, 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 abduction. Thank you. So the Lachman test is the next one on this. So I'm going to flex the knee with slightly 20% also, 20 degrees also, and with one hand stabilize the femur, while the other hand on the tibia above the tubular tuberosity, and then pull and push the tibia to assist the laxity of the anterior and the posterior ligament. So I'm going to ask you to flex for me a little bit, like 20 degrees. So at this point, my hand is on the tibia tuberosity, and I'm going to pull and push, pull and push, pull and push. So I'm going to do the same also on this one. I'm going to, with this hand, I'm going to push and pull, push and push, the same thing. So I'm going to go to the continuation of this. I'm going to do the drawer test. With the drawer test, I'm going to have patient to put, can you put your legs for me 90 degrees angle like this? So with the drawer test, I will grab the patient foot and on the upper leg and pull it in anterior or posterior to assess the laxity. So at this point, what I do is I push this in and I pull it out. Push in and out. So I do the same here. I push in and I pull it out. So, and then with McMuffin test, the medial, lateral, the tibial, and the extend the knee, looking for laxity and pain. So, in most of these tests, we are all looking for pain or any cryptos. So this one also, I pull the lateral. Can you pull this leg down now for me? So I will pull this down and extend the knee up, and I will go this way. I'll go this way. So I'm trying to get any pain while I am trying to rotate the tibia while any pain?
No pain.
Okay, and then I'll do the same thing while I'm trying to rotate the tibia. Just hold on the tibia. Any pain?
No.
Okay, so we go down to the hip. So with the hip, I will start with inspection. So, and like every exam, well, I need to see that part of the body, but with this, because we're in camera, it will not be right to be exposing my patient. So in that normal clinical setting, this patient will be, that area of the body that I'm testing will be exposed. So I'm inspecting the hip for any redness, any swelling, any nod, or any alignment, hip alignment, be it that one is higher or lower. So I'm going to palpate the anterior superior iliac, which is right here on our hip. I'm going to palpate that. I'm going to palpate the spine, the spine and the great tongue here, which, can you roll a little bit for me? So yes, this way, so that way the camera can see you. We can pick up the camera. So I'm gonna palpate the great tongue here. I'm gonna palpate the spinal and then the superior iliac. So I'm palpating it for any pain or any tenderness. So the next thing is the hip range of motion. So with the hip range of motion, I am going to be flexing the knee to 45 degrees externally and internally. So it's going to be externally, internally, externally, internally. So I will, after doing that, which is the flexing, I will also do the abduction and abduction, which is the abduction is towards the body and the abduction is away from the body. It's the hip. So away and towards the body, away and towards the body. So another test, the specialty test that I want to do here is to detect the occult hip flexion contraction, which is known as Thomas test, which we will have patients flex the right knee and pull firmly against the abdomen. This flattens if there is normal lumbar lordosis. So I want you to lay down on your back. So I will be pulling your leg up. So you flex it for me, and then I pull against the abdomen, and then watching the abdomen if it flattens. So that it gives me a normal lordosis, lumbar lordosis at this point. So I'm going to be looking at the next test, which is Patrick or Faber test. With Patrick Faber test, we extend and abduct external rotation of the hips to the test of the hip, and then for any sacroiliac joint disease. Placing patient on the left foot of the right distal